What is a skeletal muscle relaxant and what is a neuromuscular blocker? Yes, Anshu?
Skeletal muscle relaxant neuromuscular blocker blocks only at the neuromuscular junction, where skeletal muscle relaxant can be from CNS also.
Can be from, excellent. So that includes, and what are those drugs called which relax muscles from acting in the CNS? Centrally acting muscle relaxants. There are some which are actually not centrally acting, but what we also sometimes call the spasmolytics. So they relax muscles which are in spasm, while the and it's very easy to remember, though neuromuscular blockers and skeletal muscle relaxants, remember, are often used interchangeably. Please though, come here. They are often used interchangeably, okay, but there is this distinction, and it's very easy to remember. Neuromuscular blockers are the blockers at the neuromuscular junction, okay, and the skeletal muscle relaxants include the neuromuscular blockers as well as the other drugs, that is the spasmolytics. So this I've already said. Now what are the difference between the two? So we've already seen the neuromuscular blockers act at the neuromuscular junction. They relax normal muscles. They are used mostly for during general anesthesia for skeletal muscle relaxation, while the spasmolytics, they are used, so they usually act centrally, so they have CNS effects, but one of the spasmolytics, that is dantrolene, does not act centrally. Anybody can tell where does dantrolene act? Or what is dantrolene? Have you heard of dantrolene in physiology? No, okay, no problem. So we'll be discussing that. So they are used in conditions of spasticity. So we are first going to discuss the neuromuscular blockers today, and next class, that is I think tomorrow afternoon, we'll be discussing the other drugs, that is the spasmolytics. So coming to the neuromuscular blockers, so the neuromuscular blockers are drugs that relax the skeletal muscle. So we are all talking about skeletal muscle relaxants. None of these two classes are relaxing the smooth muscles. So these are all skeletal muscle relaxants. So neuromuscular blockers are drugs which relax the skeletal muscles by acting at which receptor at the neuromuscular junction? Nicotinic M. What does M stand for? The muscles. So again, that is not difficult to remember. They act at the neuromuscular junction by blocking the, I won't even say blocking, as we'll see, by acting at the nicotinic M receptor at the NMJ. So किसी को पता है? I'm sure ये physiology में discuss हुआ है. The competitive. So we have competitive neuromuscular blockers and we have the non-competitive. The competitive are also called non-depolarizing, and the non-depolarizing, or sorry, the depolarizing ones are also called non-competitive. Okay, the most common terminology is we use competitive and we use the depolarizing. We leave the negatives out of it. So we usually call them the competitive blockers as well as the depolarizing. The most common competitive blocker is, not the most common, in fact, I should say the prototype of the competitive blocker is D-tubocurarine. Now, do you go to the OTs during your clinical postings? No. Have you ever seen skeletal muscle or a neuromuscular blocker being used in the clinics? No. So anyway, and as an MBBS, anyway, you're not going to be actually using them unless you've done your post-graduation. Most commonly, it's the anesthetists who use. So that's why I didn't start with a case. So yeah, what was I saying? So they act at the neuromuscular junction. What is succinylcholine? So the most, the prototypical, or in fact, fortunately, there is only one depolarizing agent that we have to remember, that is succinylcholine. While as we'll see, for the competitive blockers, we have a number of neuromuscular blockers which act by competitive block. Though D-tubocurarine is the prototype, you will not see it being used, but because it is no longer used, and we'll see why. So this is what happens at the neuromuscular junction. I'm sure all of you are very much familiar with it. So this is your axon, the terminal, and this is the muscle and the motor end plate of the muscle. So you have an action potential coming down the axon, okay, which due to the depolarization involved in the action potential, there is opening of the voltage gated calcium channels. Calcium comes inside, and in this case, what is the main neurotransmitter which is released? Acetylcholine is released. It acts at its receptor, that is the NM type of, no, don't give, the NM type of receptor. Okay, and that is, and if the action potential is strong enough, there will be propagation of the action potential down the muscle, and the muscle will contract. If it is not strong enough, there will be no contraction. Okay, and this is the larger picture. Now why is this not turning? Yes, so this is just an enlarged picture. You are, of course, from physiology, you know very well what is the, so there is contraction, and this is called the excitation contraction coupling. Now why is this? Okay. So as I already said, the prototype competitive blocker is D-tubocurarine, and anybody knows where does D-tubocurarine come from? Anybody interested in history of medicine or history as such? Somebody was saying something. And ये नाम कहाँ से आया? Tubocurarine. D is of course the dextroisomer. Okay, so there is L-tubocurarine which is not effective. It is a D-tubocurarine which is effective. And tubo कहाँ से आया होगा? So anybody has any idea? Physiology में I'm sure कहीं ना कहीं mention हुआ होगा. कहाँ से आता है? At least the country or the continent?
Curaric arrow poisoning.
Exactly. Okay, and which continent?
South America.
South America, right? So this actually the origins somewhere they, I don't know since when they were using it in South America. It's somewhere in the 16th century that it was this, some Europeans traveling there realized that the natives of South America were using extracts of a plant called the Strychnus toxifera. Okay, and there are other related vines like the rhododendron, the chondrodendron. Okay, so what they would do is, yes, so the word curare actually comes from the Indian word urar. Indian means the North American Indian, not us, the Asian Indians. Okay, the word called urare or urali or urari. Okay, the curare actually from urare it became curare, and the tube comes from so this was actually stored in bamboo tubes. Okay, so that tube has come from the bamboo tubes in which the natives stored it. Okay, so that is how the name tubocurarine came. That's the problem with animation. Yeah, I don't know if you can appreciate the picture. It's looking very dark. Anyway, there's another picture. So that these are the native South Americans extracting that curarine alkaloid from the leaves and then applying it on the tips of the arrows, and there you can see the arrows, and the arrows could be used with a bow and arrow, but the most recorded procedure in which they used the arrows was instead of bow and arrow और क्या use कर सकते हैं arrow को throw करने के लिए? Through a pipe. नहीं, spear नहीं, arrow तो arrow ही रहेगी, but they would use a blow pipe to, because अगर हाथ से करेंगे तो probably the they will touch the toxin, maybe that is the reason. In any case, so they would use a blow pipe to kill animals using this poison on the arrows. Now the question is, if they were using this to kill the animals, you are using a poison to kill an animal. If you are shooting plain bow and arrow say spear say, it's okay. But अगर आप एक poison से एक animal को kill कर रहे हो, that poison has entered and killed the animal, how come you can eat that animal and not get poisoned yourself. Anybody wants to try answering, or shall we wait for the next few slides and then you hopefully know the answer? Anybody wants to answer now? You know any? Yes? So, but we will eat the animal along with the receptors ना. हम एनिमल के NMJ जंक्शन थोड़ी ना, और मसल तो हम खाते हैं एनिमल्स का, हम मतलब जो भी खाते हैं. हाँ, okay, ठीक है. I mean, at least you're thinking one line of thinking, but that's not the answer. We'll see the answer subsequently. So let's just go on, discuss them, and then you will get your answers yourself. So now, what about the structure of these neuromuscular blockers? So they bind to the acetylcholine receptor, that is NM. So naturally, they would have some feature of acetylcholine. In fact, succinylcholine is nothing but two molecules of acetylcholine, one after the other. Other drugs are more complex, the competitive blockers, but somewhere in their structure there is a similarity to acetylcholine. And also all of them have a quaternary compound in them, which makes them less what soluble? yahi likha hua hai, less lipid soluble, poorly lipid soluble. So now what does that mean? Poor lipid solubility means that when you take this drug orally, is it going to be absorbed or not? The lipid solubility is so poor that they are not going to be, are they going to be absorbed? A poorly lipid soluble, is it going to be absorbed in the GIT? No. So they are not going to be absorbed in the GIT. And now you have your answer to the previous question. So you can kill an animal with a poison, but when you eat that animal, you're going to eat it orally, right? Of course you are, and they may not even be cooking it. Another answer, I thought somebody would say that it's destroyed during cooking. I don't know whether actually if it's destroyed during cooking or not. Okay, but even if they didn't, because those days they wouldn't, we are talking about centuries ago, they probably didn't even cook or didn't cook properly. So even if they were having raw meat, because it's not absorbed orally, so they would not be affected. Okay, what else can you tell about the drugs, about the distribution? So you know now about the absorption, won't be absorbed orally. So that's why these drugs, remember, are only given by injection. What about distribution? What can you tell about distribution? Exactly. So they do not have, and that's why we have that other class which we call the centrally acting skeletal muscle blockers. These are the peripherally acting skeletal muscle blockers or the neuromuscular blockers. So they don't enter CNS, they are not absorbed orally. You have to give them by injection, okay, and that's why they could eat it. So mechanism of action of competitive blockers, very simple. What happens usually at the NM junction? You have acetylcholine binding at the the nicotinic M receptor, which is what kind of a receptor? This is a very simplistic picture. What kind of a receptor? That's part of your pharmacodynamics. I'm sure you know what kind of receptor is that. Ligand gated ion channel, exactly. So these are ionic, examples of ionic receptors. Okay, and so when acetylcholine binds on it, I won't ask you which sites between alpha beta and alpha delta, how many subunits the nicotinic receptor has. I'm not going into that. Don't worry, I'm not asking you. Simplistically, you should know it binds at the nicotinic receptor and causes its opening. Okay, and then what are the electrons that pass through the receptor when it's activated? Physiology and autonomic. चलो autonomic तो चल ही रहा है, pharmacology and general pharmacology. So it's sodium mainly that goes inside. A little potassium may come outside. Okay, so it's mainly a sodium channel. Okay, so that opens and there is depolarization, which causes, as we've already seen, the muscle to contract. Okay, now what happens? So it's very simple. What happens when there is a competitive blocker, like any competitive blocker, particularly in low doses? So this is your non-depolarizing or the competitive blocker that's going and binding at the same site where acetylcholine would bind at this receptor and hence prevent acetylcholine from binding, and hence there is, instead of contraction, there is paralysis. Very simple. In high doses, what can also happen is that the drug can go inside. The blockers can go inside and block the channel even from inside. So there is a more sustained block. Okay, and we'll see. So we have some short acting competitive blockers, we have intermediate acting, and we have long acting, which also depend of course on their pharmacokinetics. So this is the different kinds of actions that can happen at low or higher doses of these blockers. Now chemically, if we divide them, not very important to remember, but it's very easy to remember, and some characteristics may be a little different from them. They are of two types, the isoquinoline type and the steroid type. As we'll see, you can make out from the names. So the isoquinoline are the curium or curin. Okay, after tubercurin and metocurin, actually all the others, the isoquinoline types are named as curium, and the steroids are named as curoniums. Okay, so वो name से ही आपको पता लग जाएगा, आपको ऐसे कुछ याद करने की जरूरत नहीं है कि isoquinoline है या steroid है, you can make out from the names. So these, as I said, can also be in turn divided into different drugs depending on their duration of action. So we have short acting, intermediate acting, and long acting competitive blockers. So first, amongst the isoquinolines, the shortest acting is nevacurin, which is about 10, it acts for 10 to 20 minutes. Okay, and why is it short acting? Because it gets metabolized by plasma cholinesterase in the, where is plasma cholinesterase present? In the blood, or also it can be in the liver, that sometimes we call that as butyryl cholinesterase. So just remember, it's not the acetylcholinesterase that is degrading these drugs. If it were acetylcholinesterase, then they would not be able to act for more than a few seconds, just like acetylcholine. It's the plasma cholinesterase, or what we call the pseudocholinesterase, or the butyryl cholinesterases, which destroy these drugs. Then we have two drugs, that is etracurium and the related cis-etracurium. Etracurium at one time was used quite a bit, but now it's been replaced mostly by cis-etracurium. Now this is a very classic example of a non-enzymatic metabolism. Now this doesn't need any enzyme, it spontaneously metabolizes into a non-active form. And this kind of metabolism, or for especially cis-etracurium, this metabolism is called Hoffman elimination. Okay. So this is something आपको कभी quiz में भी, MCQs में भी या वाइवा में भी पूछा जा सकता है. Okay, so it is metabolized spontaneously. Now, so which means, so what is the advantage? कोई enzyme नहीं चाहिए, metabolize अपने आप हो गया. क्या advantage है? Otherwise, how are drugs eliminated? Either they are metabolized or they are excreted by the what is the main organ of excretory system? Kidneys. Yes. So they are either metabolized or excreted by the kidneys. So what can happen if there is hepatic disease or renal disease? You can have reduced elimination, but for a drug that is metabolized spontaneously, you can use it in either disease, whether there is renal disease or whether there is liver disease. So that's an advantage. But the problem with etracurium is that it is metabolized to a metabolite called laudanocin, and this can accumulate especially in renal failure and cause seizures. And now it's another form, that is cis etracurium, is the one that is used because it does not form laudanocin. Okay, and so there is this problem of seizures due to accumulation of laudanocin is not there with cis etracurium. So cis etracurium is very commonly used nowadays. Okay, and etracurium for that reason is not used. Both of them are intermediate acting neuromuscular blockers, act for 20 to 35 minutes. Then we have a long acting isoquinoline blocker, and in fact the prototype, what was the prototype neuromuscular blocker? T-tubercurin, that itself is long acting. And then we have metocurin, but as we'll see, they have a lot of adverse effects, so we hardly use them. Okay, and then there is another long acting one, that is doxycycline. Okay, and if you'll see, even amongst the steroids, the drugs that are excreted by the kidneys without metabolism tend to be longer acting. Okay, while the drugs that are metabolized either by cholinesterase, the drugs that are metabolized by cholinesterase tend to be the shortest acting. Then the drugs which are metabolized either spontaneously or by the liver tend to be intermediate acting, and the drugs that are excreted by the kidneys directly tend to be the longest acting. Okay, so that way it will help you to remember. Now coming to the steroids, so in fact steroids are the ones, unless we want a very short acting drug, it's the steroids that are more commonly used nowadays. We don't have a very short acting steroid, we have intermediate or long acting. But so amongst the intermediate we have two, rocuronium and vecuronium. Rocuronium is also very fast acting, so it's quite widely used nowadays as a neuromuscular blocker because it's very fast acting. And for both of them, the most major route of elimination is by hepatic metabolism. Okay, then we have long acting drugs like your pancuronium, pipicuronium. Okay, this we use if we are expecting the surgery to go on for a long time, only then we will use them. And as I've already said, long acting means the major pathway for elimination will be renal. Problem when I go back is that the slides are not changing, so I have to come forward. Okay, so that's enough. If you know that much about competitive neuromuscular blockers, their action. We'll come to the adverse effects later. We'll discuss the adverse effects together. Then what about the non-competitive or the depolarizing muscle blockers? Okay, so that, as I said, we have only one that we use. That also, now with rocuronium being very fast acting, often we, as you'll see, there are so many contraindications to succinylcholine, so rocuronium is being used very commonly in place of where earlier succinylcholine used to be used. So as I've already said, succinylcholine, also called succinylmethonium, so remember it's one and the same thing. And this is nothing but two molecules of acetylcholine together. Okay, and so what do you think the elimination route would be for this? Thank you. The elimination would be succinylcholine. How will it be eliminated? By plasma or liver choline esterase, not by acetylcholine esterase. Okay, then it won't otherwise be able to act. And duration of action still is about 4 to 8 minutes. Okay, still it is one of the shortest it is the shortest acting, very rapidly acting. It acts within a minute, okay, and very short acting. So where do you think particularly it would be useful? A very rapid and short acting neuromuscular blocker. कहीं तो आपने क्लिनिक्स में आप लोग ICUs तो जाते हो नहीं, but anyway by now do you know? Yeah, you have a problem, you have headache, excuse me. हाँ, कुछ problem है? नहीं है? Okay, then please sit up. What's your name? Huh? I know, I'm not sorry, I'm not getting it. Yes, it's not there, yeah. Can you repeat your name? Huh? Sakib. Okay, Sakib. Yeah, it would be nice if you sit up during a lecture. So, duration of action, as I said, is 4 to 8 minutes. So, आपने कहीं कुछ you know of no short procedure where a skeletal muscle blocker or a neuromuscular blocker would be useful. Now, you have been in this institute for how long now? कितना देर हो गया आप लोग को? In this institute, meaning in a medical institute, for how long? 1.5 years. तो कहीं कभी देखा नहीं, या टीवी पे ही नहीं देखा, कहीं और रियल लाइफ में नहीं देखा, सुना नहीं, कोई ऐसा शॉर्ट प्रोसीजर जिसमें न्यूरोमस्कुलर ब्लॉकर यूज किया जाता है? Okay, fine, no problem. We'll be discussing clinical uses. shortly, and this you've already said it is metabolized by plasmacholinesterase. So before, of course, the uses, so how does succinylcholine act as a neuromuscular blocker? So we have already seen that it is called a non-competitive or a depolarizing blocker. So depolarizing means, just like we saw acetylcholine binds to the nicotinic receptor and depolarizes the membrane, similarly succinylcholine also does that. So it binds at the same receptor as acetylcholine, okay, and the receptor is open as you can see, but it is blocked. Why? And block actually initially, so there will be stimulation, and in fact clinically there could be fasciculations in the beginning, but ultimately it gets blocked. Why? Because it has a very long action, so it is continuously occupying the receptor, okay, and very long means, as you've seen, it's only 4 to 8 minutes, but for how long does acetylcholine act at the receptor? Is it hours, minutes, seconds, milliseconds? It's few milliseconds. Okay, so compared to that, it is acting for a long time. And what happens at the neuromuscular junction? The motor end plate needs to be depolarized and repolarized again. Okay, for it to contract. Otherwise, so when there is continuous depolarization, it goes into a ब्लॉक. मतलब आपको कंटिन्यूस स्टिमुलेशन है तो ओवरडोज हो जाएगा. लाइक इफ यू कीप ऑन वॉचिंग Netflix, I think the mind stops. There is so much stimulation, the mind actually stops thinking. You are just watching without really knowing what you are watching. Okay, so just an example, I'm not saying don't watch Netflix. So similarly, if there is continuous stimulation, the muscle, instead of staying stimulated, it becomes, क्या हुआ, कुछ problem है? It becomes blocked, okay, and that's called a depolarizing block. And mind you, this block is, what do you think, what kind of block would this be? Is it a spastic block, or it's a paralysis? So the muscle actually goes into paralysis because of prolonged stimulation without any repolarization. Prolonged depolarization, no repolarization in between, so the muscle goes into paralysis. Now what kind of paralysis do you think this is? Is it a spastic paralysis, or is it a flaccid? You understand the word spastic and flaccid, right? So yeah, that would be the logical thinking. How many of you say it is spastic? Many of you, yes, and that is what we would think, right? Continuous stimulation would cause spastic, but no, it is a flaccid paralysis. Okay, so remember, it is a, and we would not use it as a neuromuscular blocker if it caused spastic paralysis. What we are using these neuromuscular blockers, most common uses during the surgery, especially like if there is an abdominal surgery or a thoracic surgery, or when we are doing laryngoscopy, we want to relax the muscles. If it is in a spastic paralysis, we will just defeat what we are trying to do. Okay, so it is a flaccid paralysis. So that is the strange thing about this that you should remember. Again, as I said, it's because the muscle, to maintain the contraction, it needs to get repolarized, depolarized. That cycle is required, which is not there when succinylcholine is bound to the receptor. So that is how the depolarizing block happens. So depolarizing block basically is happening just because of the prolonged stimulation. Now this is what we also call the phase 1 block. Now what happens if we are continuously giving succinylcholine? There is what is called a phase 2 block. In this, the NM receptor, okay, now becomes desensitized. So it does become repolarized. It is no longer depolarized. There is repolarization, but it is not sensitive to stimulation. Maybe succinylcholine, or it may be acetylcholine. It is no longer sensitive. The reason for the desensitization is not clear. I will not burden you with hypothesis which we don't know with what is true. So for your level, it is enough to know that the receptor, that is the NM receptor, becomes desensitized, okay, and that is called the phase 2 block of the non-competitive or the depolarizing block. So it is desensitized, it's repolarized but not responding to a stimulus. Okay, so that is called a phase 2 block. So to sum up, what are the differences? And in fact, there are some additional points which I have not in fact discussed. So what are the differences? Now these two differences are very logical, you can get from how they are acting. So tubocurarine is a competitive or a non-competitive blocker? Competitive blocker. So if you are adding tubocurarine to another competitive blocker, what do you think would be the kind of effect? Would it be additive or antagonistic? It would naturally be. So this is just common sense, it would be additive. What if we added to the depolarizing blocker? So if can we mix two of them for additive effects? No. Okay, that will actually be antagonistic. Okay, because the competitive one will even compete with succinylcholine to bind at the neuromuscular junction, okay, or at the NM receptor. So there is going to be antagonism. And similarly, of course, vice versa. If we are giving succinylcholine, we are adding it to a competitive blocker, there is going to be antagonism. But if we are adding it to a depolarizing blocker, there is going to be additive action. So this is, so all these tables will be given in your books, and so don't I mean, worry ki kya hai table mein. These are very simple things which you can understand and you can remember. Now remember, what is neostigmine? You've done the cholinergic system, right? What is neostigmine? It is an anticholine esterase. It inhibits metabolism of acetylcholine, okay, and it inhibits acetylcholine esterase also. Unlike, we've seen these drugs are not getting metabolized by acetylcholine esterase, but acetylcholine is getting metabolized by acetylcholine esterase. So what is going to happen if you give, you've given competitive blocker and now you give neostigmine? What is it going to do to the block? It will help in, will it help in reversing the block? Neostigmine, will it help in reversing a competitive blocker? Yes, it will help, and it is used, okay, for that. Neostigmine, etrofonium, they are used to reverse a block, okay. But what about the depolarizing block? So depolarizing, we are talking about phase 1 only purposely, because phase 2 resembles actually the competitive block, okay, phase 1 depolarizing. So will neostigmine be able to reverse a phase 1 depolarizing block? No, obviously not. Now what is TOF? I'm sure you know from your physiology. What is TOF? What does TOF stand for? You don't know? I'm quite sure you know. किसी को नहीं पता? सच्ची में फिजियोलॉजी में नहीं हुआ है? Krish sir, I'm looking at you, expecting at least you to answer. No? Train of 4, stimulation. Yash, train of 4, stimulation. नहीं पता? So you people are saying that physiology में train of 4 is not, you have not heard of train of 4 stimulation, or you have heard and you've forgotten. That of course you would not know if you have forgotten. Okay, so I'll tell you what it is. Now train of 4 means when you are, this is actually this is done clinically, to assess the block by these blockers clinically as well as in research. So train of 4, TOF is train of 4, which means 4 stimuli are given one after other, usually at frequency of 2 Hertz. Okay, you give 4 stimuli. So suppose this is normal. Now what happens if there is competitive block? You are giving 4 stimuli. What do you think will happen when you are giving 4 stimuli? 2 Hertz is quite a fast frequency. You are giving, that means you are giving every 0.5 second. You are giving a stimulation. So what do you think will happen in case you have given a competitive blocker? First of all, and I'm talking about, of course, partial blocks. Total block, complete block है तो कुछ भी नहीं होएगा. If there is partial block, first of all, this height will be reduced for the first itself. What will happen to subsequent stimulations when you're giving? Now what, like any synapse, there are also pre-junctional nicotinic receptors, and like most pre-junctional receptors, they are inhibitory to acetylcholine release. Okay, So what happens now when you are giving fast stimulations? In any case, the prejunctional ones are inhibited, but when you are giving fast stimulations, okay, because the prejunctional receptors are also getting stimulated, there is depletion of acetylcholine, which is, if you were giving slow contractions, okay, the acetylcholine buildup will, you know, catch up with the stimulation. But when you're giving fast stimulation, there is less acetylcholine release because of the prejunctional, you know, receptors, and there is what we call decreasing response, and this is called fade. Okay. In case of depolarizing, what do you think will happen? Again, partial block, it will be reduced, but there is no fade because it has nothing to do with the acetylcholine that is, you know, secreted. Okay, its acetylcholine is not going to antagonize it. For the same reason, neostigmine is not able to antagonize it. Okay, so acetylcholine is also not going to antagonize it, and there is no fade. Now, another differentiation, so these are called electromyographic studies. Okay, another differentiation is what is called post-tetanic stimulation or potentiation. Now, what is a tetanic stimulation? ये भी physiology ने नहीं पढ़ाया है, I'm sure पढ़ाया है, but anyway, tetanic stimulation is very fast stimulation, say 30-50 hertz stimulation. It's almost like a continuous stimulation. The muscle goes into a tetanic, you know, contraction. This is what it represents. Once you stop the stimulation, what is now happening is, so the muscle is contracted, there was a buildup of acetylcholine that was released, and if you, after a gap of few seconds, if you stimulate, there is going to be what is called this is called post-tetanic potentiation. There is going to be a higher response, and then it slowly comes back to normal. Okay, and same thing happens for competitive, only thing is the size will be smaller, and maybe the time it takes for the, you know, contraction to come back may be longer. Okay, but for depolarizing again, and sorry, same thing will happen, but there will be a fade. Okay, while for depolarizing, no fade but no post-tetanic stimulation also. Okay, acetylcholine that is building up will not antagonize acetylcholine, so there is no post-tetanic stimulation, potentiation with the depolarizing blockers. So I hope that is clear, and if it is not clear, you can just read a book. So this is just what we have discussed. So there is a fade with competitive blockers, but there is also a post-tetanic facilitation or potentiation, and with depolarizing blockers there is none of these two things happening. Now, there is also slight difference in the order of the muscles that are paralyzed, okay, but for both of them, if you see, the respiratory muscles or the diaphragm are the last to be paralyzed and the first to recover. Okay, so for the competitive blockers, it's usually from, you know, the small muscles to the large muscles, and diaphragm is less. For depolarizing, it's a little, you know, mixed here and there. You have the neck and leg and arm muscles first getting, you know, blocked, and then you have facial and pharyngeal muscles, and then lastly the respiratory muscle, and usually the response happens in the reverse direction. Recovery, we've already seen. For the competitive blocker, it will be usually longer than the depolarizing block, but the actual duration will depend on the individual drugs that we have seen. We have long acting, intermediate acting, and short acting, while for depolarizing, so we have only one drug, succinylcholine. The action is for 4 to 8 minutes. Fasciculations. Now, in case of a competitive blocker, naturally there are no fasciculations in the beginning, but as we've already discussed, for the depolarizing blocker, because it actually stimulates the receptor, so initially the patients may have some fasciculations which are probably associated with pain after the surgery, though nowadays it's a little contested. We are not very sure whether the pain that the patient complains of after surgery, muscle pains, are because of that or not. The other thing is, earlier what used to be done is that we would give, so if we were using succinylcholine, we'll give a small non-blocking dose of one of the competitive blockers. Okay, but that would increase the dose required for succinylcholine. So that's usually not recommended. What was called precurarization, okay, that is not recommended anymore. That's a tongue twister, so I'm happy that it is not being done anymore. Okay, so now finally the uses, which one or two I've already mentioned. So what are the uses of neuromuscular blockers? The most common use is during surgery. Okay, we want to relax the, especially intra-abdominal or thoracic one, first of all we are doing, or we are doing an orthopedic surgery, we want to relax the surrounding muscles so we can align. So suppose we are doing a fracture correction and, we need to align the bones together, and if the muscles are very stiff and contracted, we won't be able to do it. So to relax the muscles, we use we use neuromuscular blockers. Now, general anesthesia is over for you, class. So you would know that general anesthetics also in higher doses most of them would cause skeletal muscle relaxation. So why is it better to use a combination of a general anesthetic with a neuromuscular blocker instead of just a general anesthetic? And what is the term for this? Combining drugs in general anesthesia instead of giving high dose of one drug to achieve everything that we want. मैं ये GA वाला lecture से question पूछ रही हूँ. What is the advantage of that? What is it first of all term for that? So you are using, we are talking about two drugs now, GA and neuromuscular blockers combined to provide skeletal muscle relaxation instead of giving a high dose of GA. Okay, and similarly we can combine some other drugs. For additional analgesia, we combine opioids. Okay, and what is the term for this? What kind of anesthesia? Sadik. Yes, Sadik. What kind of analgesia this is called? Or anybody else? Nobody from general anesthesia? So this is called balanced anesthesia, okay, instead of just a high dose of one drug. And of course, if you're using a high dose of a general anesthetic, then there is more, danger of adverse effects due to the general anesthetic. So it is better to, so now because of neuromuscular blockers, we can use lower doses of the general anesthetic and get skeletal muscle relaxation with a neuromuscular blocker. So during surgery, orthopedic, and a very common use during emergencies in the ICUs is for laryngoscopy, okay, or to put an endotracheal tube, okay, we use, and for this we would want to use a rapidly acting but a short acting one. So as I said, succinylcholine or rocuronium are the ones that are mostly used for these. Then the another use is again ICU. Patient is in a critically ill patient, and you need to put the patient on a ventilator, but the patient's muscles would also be contracting, and anybody has any question? So the person's own muscles are also contracting, and we can say competing with the ventilator. So at those times we want to paralyze the patient's muscles, and we do that with a neuromuscular blocker. Okay, so that's another very important use. Then uses which are not very commonly used, especially the first one is, but again I think anti-epileptics is over. You would have, no, not yet. Okay, you would be discussing. So it's kind of the last resort therapy if patient is having what we call status epilepticus, patient is having convulsions. That is particularly the GTC ones, the generalized tonic-clonic ones. Patient is not responding to you've tried anti-epileptics, you can even try general anesthesia, propofol IV is given, still patient is not responding. Last resort is to give the patient a skeletal muscle blocker. That is just to stop the skeletal muscle contractions. Actually, the seizure activity in the CNS is not going to stop, but because the skeletal muscle contraction itself is life-threatening. Okay, so to stop that, you may use these drugs. Similarly, for ECT, do you know what is ECT? I'm sure you know, and what is it used for? Electroconvulsive therapy is sometimes used for, again, as a kind of, I won't say last resort, but in psychiatry, patients who are not responding to other treatments, okay, certain psychiatric disorders, we use ECT. Has anybody seen a patient getting ECT in a movie? कोई movie? हिंदी, तमिल, मलयालम, कभी मूवी में कभी देखा नहीं है पेशेंट को? स्पेशली द ओल्डर वंस, probably this generation you have not seen. Anybody has any idea of how does it look like? किसी को ECT मिल रहा है? Okay, so why I was asking whether you've seen it in the movies, because in the movies they will show the patient, having these convulsions while we are giving ECT, but usually that is not what happens. We usually give a neuromuscular blocker. So again, in ECT, we want to give the brain stimulation. We don't want the patients to have convulsions. So usually when we are giving ECT, we give neuromuscular blockers to relax the skeletal muscles and then give ECT. Okay. So now lastly, coming to the adverse effects of these drugs. Yeah, we didn't have that 1 minute break आज ना, but ठीक है, अभी खत्म ही कर देते हैं. So lastly, coming to the adverse effects of the, anybody has any question till now? अभी पानी पीना था आपको, पी लो, अभी पी लो, पीछे मांग रहे थे, पी लिया तो पी लो ना. अभी बीच में आप डिस्टर्ब कर रहे हो, क्लास 5 मिनट स्टार्ट हुए नहीं, एंड यू वांट टू हैव वाटर. And that also, if you have yourself, you drink, but if you're not having, don't disturb others. हर्ष, और किसी को पानी पीना है, पी लो. Okay, so now coming to the adverse effects. Now, so these are three, classic adverse effects which many of them have, and we'll just discuss together. So, as I said, I'm discussing adverse effects together for all of these drugs, the competitive and the non-competitive. Okay, so one common problem is release of histamine, and what could the release of histamine lead to? So why is that a problem if there is histamine release? It could cause itching. It could cause blood pressure पे क्या? There could be hypotension because of vasodilation. Okay, so that's why we need to be aware that these drugs can cause release of histamine. Okay, there could also be some bronchoconstriction. Okay, now the ones that cause moderate histamine, release are tibocurarine and mivocurium. Okay, amongst the competitive ones, and atracurine, metocurine cause only slight histamine release. And amongst depolarizing, that is succinylcholine. Now I'll just call it succinylcholine because that's the only depolarizing agent that we ever use. Okay, that also causes slight histamine release. That means it can cause decrease in blood pressure. But as we'll see, succinylcholine also stimulates autonomic ganglia, which means both sympathetic and parasympathetic. Okay, and in which case it can cause due to sympathetic ganglion stimulation. Okay, please wake him up, the person next to you. Yes, what's your name? Huh? Sai. Shri what? Shri Hans. Yeah, are you okay? Yeah, then please then don't put your head down and sleep in my class. Sit down. Yeah, so, and it's very distracting. Right now I've forgotten what I was saying. So if there is, predominant, yeah, so there is autonomic ganglion stimulation, and autonomic ganglion stimulation means both sympathetic as well as the parasympathetic, ganglia have nicotinic N receptors, right? Which means both sympathetic as well as parasympathetic stimulation can happen, and what predominates will depend on what is the predominant tone in the organ. Okay, so there can be in fact increased blood pressure or tachycardia because of the autonomic ganglion, sympathetic autonomic ganglion stimulation by succinylcholine, while the histamine release tends to cause hypotension. What about effect on muscarinic receptors. Now, succinylcholine is not specific for the neuromuscular or for the nicotinic receptor. It can also stimulate the muscarinic receptors. And what can happen if there is cardiac muscarinic receptor stimulation? What would happen? There is cardiac muscarinic stimulation. Which are the first of all receptors there? M2. Okay, and what would happen if there is stimulation of the muscarinic receptors in the heart? There would be, yes, there could be bradycardia. So succinylcholine can have so many effects. While if there is hypotension, there could be reflex tachycardia due to sympathetic ganglion stimulation. Also, there could be increased heart rate, but there can also be a direct effect on muscarinic receptors. So basically, you have to be prepared for these different effects on the cardiac system that succinylcholine can have. While for the competitive one, we've already seen they can be histamine release. Some of them only, that is tibicurarine, metocurine, the older ones which are actually now both of them are not used, could cause a weak block, okay, of the autonomic ganglia, and some of them can also block the, so remember the competitive ones will block and the depolarizing ones will stimulate these receptors, whether it is the ganglionic or the muscarinic receptors. So some of the competitive blockers like pancuronium cause a moderate block of muscarinic receptors, which would lead to tachycardia, okay, and procuronium causes a slight block. It can cause a slight tachycardia. Then coming, so as I've already said, tibicurarine and metocurine are not commonly used nowadays. Then let's look at, now succinylcholine has some typical adverse effects which can be very serious and which have to be, which form a lot of contraindications for this drug, okay. Now one of them is potassium release causing hyperkalemia. Now when muscles contract, there tends to be release of potassium from the muscles, okay, and there are also some, this usually doesn't matter for a normal person, but anybody has any questions? I can hear some talking. कोई question है तो मुझसे पूछो. Yeah, so what was I saying? Now besides the neuromuscular junction, there are these nicotinic NM receptors along the, around the motor end plate on the muscles, and which tend to proliferate for some reason if a patient has burns or if a patient has some neuromuscular disease like your AML or AMLS, okay. Now especially in these patients, what will happen if you are giving succinylcholine? There can be an increased release of potassium from the muscles because there are more of these receptors. Okay, so especially for these patients, we avoid succinylcholine, or if at all we use, we have to use very low doses. Another problem can happen in patients with glaucoma, with increased IOP. There can be, because of the initial fasciculations, there can be contraction of the myofibrils in the eyeball, which could lead to increased IOP. So, or it could also be because of dilation of the ocular blood vessels, which could cause, that is the choroidal blood vessels, which could cause an increase in IOP. Similarly, the initial muscle fasciculations can cause an increase in intragastric pressure, which could lead to nausea or even vomiting. And as I've already said, the muscle fasciculations may be responsible for the post-op pain that the patients have. Okay, then lastly, one very serious adverse effects which can happen with succinylcholine, especially it seems to happen when succinylcholine is used followed by general anesthesia or with general anesthesia, not when we are using only for laryngoscopy. When we are using it with general anesthesia, there is what is called malignant hyperthermia can happen, and this especially there are some people who are prone to it. Now, so have you heard of what is malignant hyperthermia from your physiology? Malignant hypothermia कहीं याद आ रहा है? Physiology में पढ़ा होगा, I am sure. Okay. So basically, now what happens in when we are giving both of these drugs together, especially there is a massive release of calcium from what we call the ranodin, especially the ranodin R1 receptors. Okay, which are there on the, where are these receptors? In the tubule, in the T tubules. Okay, and where are these T tubules? Okay, yeah, let me show you the next diagram. I think it will become more clear. So what happens is there is a massive release of calcium from the intracellular calcium stores, okay, and there, which leads to muscle contraction, which leads in lactic acid production and buildup, and there is an increased body temperature. And this we'll discuss a little bit more when we are doing dantrolene, because dantrolene is the main. So we try to control the patient's body temperature, okay, as well as the acidosis, and we also give dantrolene. That's the major use of dantrolene. So this is, now if you can see, so it is from the, what is SR? Sarcoplasmic reticulum, okay, where we have these calcium stores. And so when there is increased stimulation of the R or the ryanodine receptor, there is increase or a massive release of calcium, which leads to muscle contraction, which leads to generation of heat. So there is increase temperature, there is rigor, that is contraction of the muscle, okay, as well as there is lactic acid buildup. Okay, so this is a very, so this is especially, now it has been identified that there are patients who have mutations of ryanodine receptor and they are more susceptible to malignant hyperthermia with these drugs. Okay. Then do you remember from pharmacogenetics, general pharmacology, sleep apnea, succinylcholine? I hope you remember. There are patients who have reduced pseudocholine esterase or butyrylcholine esterase. There is a genetic abnormality, okay, and they are unable to metabolize acetylcholine or succinylcholine. So succinylcholine, you would expect the duration of action to be just 4 to 8 minutes. 5 to 10 minutes भी आप expect कर सकते हो. It's easier to remember if you remember like that. But what happens sometimes in the recovery room, you assume कि okay वो तो short acting था, अब तो कब से हो, effect would be gone, and you are not watchful. And in fact I mean I know somebody, a very good friend's brother has a young person has passed away like that. So there was no, you expect that the recovery has happened, but the recovery sometimes may not happen because there is a defective pseudocholine esterase. Succinylcholine is not metabolized, it is still acting, and there is no, patient is now off the ventilator, okay, and patient suddenly found not breathing and dead. So this is something that can happen. It's rare genetic problem. It's not still recommended to be tested routinely, but somebody, if there is at least a family history, then you could either do the testing or you avoid succinylcholine altogether in that family. And how could you test? We test this deficiency, the butyrylcholine or pseudocholine esterase deficiency, by a test called Dubocane number. Now what does it do? So Dubocane, from cane, if you can guess, it's a local anesthetic, and it inhibits 80% of the normal pseudocholine esterase, but it inhibits only 20% of a genetically mutated pseudocholine esterase. So if the Dubocane number comes 80% or more, it's normal. If it comes to 20% or less, you are probably homozygous for the defect, and if it is in between, you are probably heterozygous for the defect. So this is just a recap of your general pharmacology. I please go and read general pharmacology again. Okay, I think we'll do reversal tomorrow. We have one more day. Yeah, we'll do the reversal tomorrow. It's 10. You have to go to the clinics, right? and we haven't taken the attendance. Yeah. So can somebody come? Who's the seer? Still Subhash? You are Subhash. Yeah. Can you come and take the attendance, please? And if you remember from the last class, attendance, he'll call the roll numbers, but you, instead of saying present, please say your names. So I can know some names. And do you need the mic? Okay. And you need the register or just a piece of paper? Paper is better. Okay. Then I'll put it here later. So can somebody give him a piece of paper? Here, okay.
1, 2, 3, 4, 5, 5, 6, 7, 8, 9,
Name please. Otherwise, please call them absent if they are not saying their name. Name. 9, roll number, that was 9, right? What was the last roll number for?
9.
9, who's 9? So is that a proxy? I heard you say, yeah, I've seen you, they say, yeah, yes. You have to raise your hand. Okay, now
10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 55, 55, 56, 57, 58, 59, 60, 61, 64, 65, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 2, 103, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
नहीं कर रही हाँ नहीं घबराहट वबराहट तो नहीं हो रही तो काय को घबराहट हो रही क्या सोच रही अरे तो जब उन्हें फिकर नहीं है मैं बिल्कुल भी फिकर नहीं है काय की सोच रही थी दिमाग से निकाल दो, हैं? वो वो चीज अगर वो सोच थी अपन भी कहने के लिए अगर कहीं लोग बोला वो तो कहेंगे ना कि हमारे घरे रह रही थी कहीं हैं? हमारे साथ रह रही थी तो हमसे कह रहे थे लोग क्यों तो मैं यूज क्यों हैं? हमारे साथ रहती तो हम कहते तुम हमसे कहने के हकदार थी उनका कुछ तो टेंशन पड़ी जो बोले नहीं होगा मामा तो टेंशन तो वो तो आई जब से आएंगे जब से कभी सुखी रहे हैं कभी रहे सुखी जब से जब से ब्याह करो जब से आज तक सुखी नहीं हुई हैं जब अपना इंसान ही चलोगा बाकी उनकी वजह से तो फिर कहीं है टेंशन मत लो उनको खाओ पियो आराम करो वो तो खूब घूम रही फिर रही है भाई मैयो आराम में काम कर रही है और वो घूम रही फिर रही है हैं? हाँ।